for the seminar today in men's sexual wellness. Today, we're going to talk about why this is so important and steps that any of you can take if you're having any concerns. I am Dr. Jaclyn Milose. I did my training at the University of Michigan, Boston University. I did my residency at the University of Michigan. And then I went and I have done a fellowship in reconstructive urology at Northwestern University. And then I came back to Michigan to practice. I specialize in urinary stricture disease, blockages, erectile dysfunction, overactive bladder, incontinence, Peyronie's disease. I personally practice out of the Dearborn office, although we do have numerous physicians kind of all across the area who are all really well equipped to deal with a lot of these issues. So, why I talk about sexual wellness is because it's really important. It's important not only for our physical health, but also our overall health, our, long term for us as both men and women. And it's really important for this. So it's something that we address. A study at West Virginia University found that women are generally more knowledgeable about sexual health than men. Women were more likely than men to seek health advice at an urgent care or a walk-in clinic. And women were significantly more likely to answer questions about sexual health knowledgeably and accurately as compared to men. So, a big part of this is encouraging and educating so that you guys can feel empowered, to ask questions about your own health. 44% of men are worried about erectile dysfunction. 39% of men in the study done by the Cleveland Clinic survey were worried about the loss of sex drive. And 36% of men are worried about low testosterone. Yet only 2 in 5 men in this survey sought professional help. So the list of topics that we're going to cover today are low testosterone, Peyronie's disease, vasectomy, premature ejaculation, infertility, and erectile dysfunction. So to get us started, we're going to talk a little bit about low testosterone. Low testosterone is when a man's body has less testosterone than normal. The rate of identifying this low testosterone tends to increase with age. So we're going to see it higher in older men, like higher rates of it. It's more common in men who have obesity, have diabetes, high cholesterol, high blood pressure. The symptoms that you may feel are potentially loss of energy, fatigue. You may notice decreased muscle or strength, increase in body fat, loss of hair, hot flashes and sweats, or reduced sex drive. I think the most common ones I hear are going to be that reduced energy, the muscle mass, and the sex drive. But it also affects us emotionally, and I think that's really important. So just kind of feeling sad or blue, feeling less motivated to do things, less confidence, less enthusiasm, kind of feeling like you can't concentrate, or memory issues can affect all these issues as well. It's not just sexual health. It also helps with our bone, our cardiac, and like we talked about, a lot of that mental and psychological health. So anyone whose testosterone is low and has some symptoms certainly can benefit from a treatment, but it should definitely be a physician that's managing it. There are lots of options, and so it's important that after being tested, you do speak with a provider to figure out which is best for you. But some of these options, maybe there are gels that we can use, and these just get applied to the skin. There are some oral pills that people can take, sprays, patches, pellets, injections. There's several different ways to get testosterone replacement therapy. The next topic is Peyronie's disease, which is a curvature of the penis. This is a condition that causes a penile curvature, indentation, and or loss of length upon erection. It results of basically what happens is a man will get scar tissue that's going to form inside the penis. And the scar tissue is going to restrict the penis's ability to fully expand when erect, which in some people just manifests in loss of length, erection issues, but also most predominantly what we're going to see is that curvature that's bringing men into the office. It's more common under the age of 50, but it's certainly in all comers. It's significantly undertreated. There was actually there's a company that does some treatment options, and they did like an ad campaign a few years back. I don't know if any of you have seen it, but they had kind of like crooked vegetables on television, and it was really wonderful because it really, I think, gave a lot of men information and made men feel like a little bit less embarrassed and more likely to kind of seek out care because they understood what was happening. Only about 6 to 10% of men have Peyronie's, according to the statistics, but the reality is it's probably so much more, and we're really underserving this population. Signs are you're going to notice that you get this curvature with an erection, right? It's not something that you've like been born with your whole life. This is not like a mild curve. This is something that's a new onset. It can have a slow onset or a rapid onset, but it's new. Loss of length, pain with erection, and it can also have, we can show signs with just erectile dysfunction as well. There are numerous treatment options. There can be these traction devices that kind of help manipulate the plaque and loosen it and help with straightening. There are medications that we can inject into the plaque. These are wonderfully useful. We're really, really significantly changed management with these injections. It's really safe. It's office-based. Men see a really significant improvement in curvature with it. I've been really happy with it. And there's also surgeries. There are some people who have more, different timelines, different degrees of curvature, different other extenuating, situations that they're dealing with, in which surgery might be a better option. We can just straighten it. You can incise the graft or the plaque itself, and graft it. And then there's implants. Implants are a wonderful way for men who are having both the curvature and erectile dysfunction to get functional, right? Because the goal of this is functionality. We want to make sure you're able to be rigid enough for erection, and also straight enough for penetration so that you can have satisfactory intercourse. I mean, that's really the goal. Implants, like I said, are for like a specific group of people, but they're wonderful for those people, and they really give back that quality of life. Premature ejaculation. So it's one of the most common forms of male sexual dysfunction. It occurs when a man climaxes before he wants to. There's no kind of set amount of time, but it's classically within about a minute of sexual activity or intercourse. There's both like emotional and physical causes. Sometimes with a new partner, it can happen a little more often. If it's been a really long time since our last ejaculation, anxiety, guilt, depression can be sort of concomitant issues. There can be an underlying hormonal issue, side effects of other medications that we're taking. There are a lot of options. And so it's really important, again, that if we're having this issue, if it's something that's affecting your sexual function and your quality of your sex life, to reach out. There are, some behavioral changes that we can make, whether that be some therapy, whether that be some relaxation techniques, whether that be maybe reducing some of the things in our life that are contributing, like tobacco or alcohol or drug use. There are also medications, actually, which will delay or inhibit orgasm. So a lot of these medicines are interesting because they weren't classically prescribed as this. They were classically prescribed as antidepressants, although that's not what we're treating. And then they noticed that in this group of men, they would have delayed, orgasm and delayed ejaculation. And so it's now used for that purpose. And a lot of men, what a lot of men choose to do is actually like a topical therapy. It's a great option where you can use some numbing creams and sprays about 10 to 15 minutes before sex, kind of reduces that sensation, and it'll help delay that ejaculation. And we can prescribe that to you in the office. Vasectomy. A vasectomy is a way of performing permanent sterility. It's usually just performed in the office. It's actually quite easy. We do some numbing medicine. A physician will do it. There's a little, poke and a burn to get numbed, but men classically tolerate the procedure really well. In order to, perform this procedure, you have 2 testicles, classically, but of course you'd have an exam, and there are 2 vas deferens. And what we want to do is we want to take each vas deferens and kind of block or obstruct the flow of the sperm from the testicle. It usually takes about 15 to 30 minutes. I think 15 to 20 classically, really, in the office. you're going to be sore for a couple of days, and maybe you're not going to be doing like really, strenuous activity the next day. I usually tell people to take it easy, for a couple of days. But after that, people are really back to normal quite quickly. um, common myths that people hear about are that it's going to affect their ability to have sex or orgasm. It doesn't. It's not going to visibly change your semen. It also, importantly, is not going to prevent STDs. Those are completely different, and normal protection would have to be maintained for that. um, at our offices, a lot of them we're offering this nitrous oxide, which is like that laughing gas that you get or some people maybe got at the dentist, which is really nice for patients that can really kind of take the edge off. A little bit of sedation, it just kind of helps you relax during the procedure. You just kind of breathe in some air. It wears off very quickly so that you don't even need like a driver, which is really nice for people. Infertility is another issue that can affect a significant amount of men. 30 to 50% of cases are going to stem from male-related problems. 20% of couples are affected. Only 1 to 2% of couples are actually sterile. 50% of those who seek help can eventually bear a child. Possible problems. It can be a hormonal problem. There can be blockages. Varicocele are these dilated veins that we sometimes see around the testicle. Tumors in the testicle or the pituitary gland. Retrograde ejaculation, that's going to be when a man does ejaculate, but it goes back into the bladder. And so we're not really getting that sperm to be deposited where we need it. Or it can be low sperm count or motility issues of the sperm. It can be genetic causes. And there's also a lot of temporary causes. And, if we have these prolonged exposures to heat, chemicals, medications can kind of temporarily reduce our sperm production. And so if we remove these things, we can get that sperm quality back where it needs to be. Diseases that are linked to infertility often include colitis, diabetes, multiple sclerosis, spinal cord injuries, mumps, and cancers. Diagnosing infertility is going to be performed with a semen analysis. I'm going to check the urine to look at protein and sugar levels. You're going to get a blood test to look at your pituitary level. Some hormones will be tested. If on exam, and when an exam would be done, of course, if we suspect a varicocele, then an ultrasound may be obtained to confirm that. And in some cases, it may proceed based on those other findings to a biopsy to see if there's any sperm that's inside the testicle. We often recommend a lot of lifestyle changes, which would be like a low-fat diet, exercise, avoiding caffeine and alcohol, and eliminating marijuana. In some instances, there are going to be surgeries that can help correct abnormalities. For example, if you're diagnosed with a varicocele, those are things that can be treated through a small incision above the scrotum. If someone's had a vasectomy, you can try to reverse the vasectomy. In order to do that, you have to remove that scarred segment and kind of reattach the two ends. You can identify obstructed ejaculatory ducts, and in order we can unroof that obstruction. And then cryptorchidism is when we have a testicle that hasn't really distended and it's not really performing. Erectile dysfunction, very important hot topic. It is the ongoing of inability to achieve or maintain an erection firm enough to have sexual intercourse. 1 in 5 men over the age of 20 years old experience erectile dysfunction in their lifetime. I think that's a really important number to look at. It's so much higher than I think most men think. More than half of men that are over the age of 50 have some degree of erectile dysfunction. 40% of men are affected at age 40, and 70% of men are affected at age 70. So there's a significant number of men who are dealing with this issue. It's in a total, but they kind of approximate that in general with all age groups, it's approximately 30 million American men that are affected. So, how does this happen? How do erections work? An erection is like a really complex mechanism between the arteries, the veins, and the nerves in the penis. When the way that the blood comes in and kind of the way that the blood flows out. First, it requires arousal, which is going to be that stimulation in the nerves. The nerves are going to release a little neurotransmitter, and then the muscles around the arteries are going to relax, and that allows all that blood to flow in. But that additional blood will make the penis stiff and hard. And then the erection itself is going to compress the veins to keep that blood inside the shaft so that we can maintain that erection for sexual activity. There are many causes of erectile dysfunction. 70% can be related to health issues, and then there's a lot of other causes as well. We have vascular disease, diabetes, obesity, smoking, medications, prior pelvic surgeries. Low testosterone can certainly contribute to it, although it's not like a direct cause. Having history of radiation, depression, anxiety, having treatments for prostate cancer. I always like to tell my patients, things that are good for your heart are good for your penis. So it's the same blood vessels, they're just very small. And so, the general things that, you would hear from a doctor to stay healthy are going to be healthy for your penis. So diet, exercise, losing weight, things that are easier said than done, but like super important. Limiting our alcohol intake, quitting smoking. Smoking is a huge one. Reducing stress, making sure we're getting the amount of sleep that we need. These are all really, really important. So what can we do? Let's say we're experiencing it. There's usually, we say, like a spectrum of options, and we kind of go from the less invasive thing and we kind of do stepwise to more invasive. But I think what's really, really cool to note, like through this journey, is that at the end of the day, we can help you get erections. So we'll start with the least after those lifestyle sort of modifications and limiting things that could be contributing to it. We have oral medications. What they're going to do is they're going to just help increase that blood flow to the penis. It's going to require sexual stimulation still, because we still need those nerves to kind of initiate the activity. It's effective for about 50 to 85% of men. It's not as effective for men with diabetes or who have had prostate surgery. The problem with those situations is kind of like we talked about, the nerves have to kind of initiate this. And so if our nerves have been affected by diabetes or surgery, they may not be available to initiate the whole event. Without that, the pills aren't going to be quite as effective, and we're going to see some higher fall off rates, from the medications. So I always, again, tell my patients, really, really good control of our diabetes is so important if we happen to have that. Getting those blood sugars under control gives us that chance to, improve our function, and more importantly, kind of preserve the function that we have. And that's really important. These medications, you're going to see variable coverage by the insurance companies. They tend to take at least about 1 to 2 hours of work. I usually tell people to kind of give it on the side of 2 hours. And then they're going to last for a variety of either 4 to 36 hours, just depending on what medication that we use. Potential side effects that some people really are going to complain about is headaches, facial flushing. That can be really bothersome. I get a lot of hearing about the headaches, nasal congestion, vision changing, or prolonged erections. Getting that prolonged erection is quite rare as long as the medication is used, as prescribed, but certainly, it's something to talk about. And then again, you never know. Some men are going to get it mild. Some people are going to get higher. The next option, or one of the options, is going to be the vacuum device. It's effective in a variable rate of men. It says 68 to 80 according to statistics. Clinically, it might not be quite that high. Like I say, 86% of men are going to go on to other treatments. So while it might work, there's this lack of spontaneity to it. I find that people really complain about the discomfort. It's just this tight band around the base of our penis, not being quite as rigid as we need to be. but also really, sometimes people will complain that, the shaft is quite kind of cold. And there can be that side effect that people don't like. It basically, you put this hollow tube over the penis, and then either battery powered or hand powered, we're going to kind of create a vacuum that pulls blood into the penis, and then a tight band. This, is going to go paste at the base of the penis to kind of hold the blood in and maintain that erection. Injections. Every time I mention injections, I get the same look on a person's face, and I totally get why. It sounds horrifying, but it's not as bad as people think it sounds. It is a self-injection, right? So it's not like a treatment that you get once a month. It's something that you have to do each time you want to have the erection. Patients are taught how to do this. We don't just send you home blind. The erection is classically going to take about 5 to 20 minutes after injection to kind of be in full force. The medication often has to be refrigerated. It has a short shelf life. What that means is it'll expire if you don't use it. And so the timing of that can be challenging for people. And often we have to use these really specialized pharmacies. Not all pharmacies are going to carry this. But it can be a really good option for some men. I have some men who want to try it. Some men it's not for them. A lot of people I think just knowing you can try it. 60% of men are going to see success with this. But, again, we're going to see some men fall off of it either because we're not getting the success that we need. Pain, they just find it to be too uncomfortable. Most don't report very significant pain, but I do have some people who say they don't like it or the burn. There is a risk of a prolonged erection. Again, it's quite rare if the medication is used as prescribed. However, it's something we always warn our patients about. Getting a little collection of blood under the skin, or just not getting the results that you want, and that certainly would be a reason to go on to other therapy. Shockwave. Shockwave lithotripsy has been very interesting new therapy. It's the goal of shockwave is going to be to help restore normal kind of natural function. You're going to have 6 15-minute visits in the office. And basically what it is these low intensity shock waves. And the therapist is going to treat multiple areas on the penis with this wand. And basically we're trying to get improved blood flow. We're using a focal versus a radial wave for just more precise targeting. There's no side effects. So the benefit is that there's really no downside. There's no pain. There's no possible real complications. There is the potential to reduce erectile dysfunction, or just to maybe not need meds or not need as high of a dose of medications, which is really encouraging. And then finally, the thing that kind of works when nothing else works is going to be the implant. The implant is a really good option for people who other things are not working. There's different kinds of devices that can get implanted. Most often it's going to be an inflatable, which is a 3-piece device, which allows for the most rigid erection and the most flaccid erection. So it's like simulating the most natural erection for people, so they don't feel like they're walking around with erection, but that it can also get nice and hard. There's also a malleable that's going to be used in certain situations. And that's something that's like these 2 rods that are going to be on each side of the corporal bodies. There's 2 of them. And it's kind of always kind of semi-hard, and we can kind of bend it into certain positions. So down, so it's not like obtrusive, and maybe into a more rigid position for penetration when that's desired. So we want to basically do is give this option to men, because there are going to be some people that are really good candidates for them, specifically people, where we've tried the other things and either we're not getting desirable results or we're getting these inconsistent results. I do think is another one. What I always talk to men about here is what you're gaining with the pump is this no more of will it work, won't it work, that, sort of questioning that inconsistency, right? Which I really think in some situations can lead to a lot of psychological sort of trauma. It can be really challenging for partners. There can be that level of disappointment, which I then think, puts a lot of pressure, on our patients and their partners. The nice thing about the pump again is, once you get it in, that thing's going to work. So for a lot of my patients, I really think it gives them a lot of that confidence back, which really just brings so much more of their vitality and like their enjoyment with sexual activity, which is can be really, really nice. Of course, it's a surgery, so there's risks to it. Infection is a risk. Having device malfunction over time is a risk. These rates are very low, but they're relevant. 90% of men are going to be satisfied with their erections. So I think those are all of our topics. We kind of just wanted to, brush through, a lot of really important topics for men's sexual health. I think it's really important to talk to your urologist, get a urologist, talk to one of us about these issues if they're a concern. There are a lot of options, and I think, knowing that you have those options is really like the first step. There is a question box if you guys have any questions. We're going to try to hit on some of the ones, or most of them, as much as we can, that are kind of just relevant to kind of generalized questions here. So, okay, let me look here. One is, okay, I have a question discussing the relationship between testosterone and prostate cancer, and whether or not like testosterone injections will cause prostate cancer. And the answer is no. Testosterone is not going to cause prostate cancer. We do counsel our patient when they are receiving testosterone therapy that we do need to have very close and accurate screening for prostate cancer, meaning with a rectal exam, a PSA, checks while we're on that therapy. It's not that it can cause cancer. It's just that if there were potential cancer cells already there, we wouldn't want to be stimulating their growth. So if we identified a cancer, we would stop that therapy until, you were treated. To check those levels, it's going to be a blood test. Classically, we're going to obtain those levels in more of like the morning owls. Excuse me, not owls, hours. Hormone levels tend to kind of vary throughout the day. So we like to get morning levels. In addition to the testosterone level, we often will get some other hormone panels as well to see if they can be related, or specifically if that testosterone's low, we're going to want to look at some other hormones because it is in the pituitary axis and make sure it isn't another hormone that's making our testosterone low. No, there isn't a specific therapy that is on label for reaching climax. Penile pump surgeries. So because I specialize in reconstructive urology, what you're going to see is that reconstructive urologists with sort of that fellowship training, we tend to do like what we consider like a more of a higher volume number of implants. It was asked about, how many a year. Off the top of my head, I want to say 30, 40. I'd have to count. But a lot, right? And is this someone, again, who specializes it? This is something we do like every week, every day. And there are several providers, that do that. Okay. Okay, this is a question about incontinence during erections. And it's someone who looks like prostate surgery. That one's going to be a little hard to answer. Basically, the question is, during sex or orgasm, he urinates a little bit, and it has to know if anything can be done about that issue. And I'd say, likely yes. I mean, there's certainly a couple different issues that could be going on. And I think you would need to go in and be seen, and we'd have to kind of run through, some of the other symptoms that we're having to kind of identify the issue. But certainly there are several options for you. 10 years ago, I received treatment for Peyronie's, and it was moderately successful. Injections and massaging of my penis. Are the injections you mentioned something that's been developed or improved in the last few years? Great question. 10 years ago, no, this would have been something totally different. There have been, I'll say this, There have been many attempts at reducing the curvatures and Peyronie's over the years, most of which have been really unsuccessful. Or I shouldn't say unsuccessful, but just like really modest results. Now, with good data behind the reduction of curvature. They did these nice randomized controlled studies, and we're seeing there's some really good improvements. On average, it's 30% according to the data. But certainly, I would say, if you asked me 2 or 3 years ago, I would tell you that most of Peyronie's we managed, with surgery. We just corrected the curvature because there just wasn't another good option. But I would say the vast majority of the Peyronie's that I see now are being managed with injections, and people are doing just really, really well. The nice thing too about the injections is you're not really burning any bridges. So if it isn't successful, if you're in that small percentage that's not getting the reduction in curvature that you're looking for, that you then can still proceed to surgery if that's an issue. I got a question about whether or not I prefer the AMS 700 or the Titan implant. What surgery location for the implant do you generally use? So no, I don't have a strong preference. They're both really good. They're both really, really good models. So there's two different companies that are the biggest competitors for making the prosthetic. I like that there's two competitors because I think they're always kind of pushing each other and they're advancing technology. They're both wonderful. People have really high patient satisfaction rates, really good results. You'll find that some providers or implant surgeons are going to place this implant via the penis scrotal incision, which is going to be right in between where kind of the penis and the scrotum meet. And some people do them infrapubically, both with very good outcomes. I personally prefer the penis scrotal approach. I'm very happy with that. Really high patient satisfaction rates, but that's really just going to be, based on surgeon preference. Next question. How is suspected low testosterone confirmed? So the low testosterone is just going to be with a blood test. And so, yeah, classically that is covered by the insurance. I believe I haven't had an issue, although don't quote me on that one. But yes, that's classically not an issue. Are the generic medications as effective as the name brands? What I tell people is everybody's different, right? Classically, we're going to get pretty similar responses. Do I see people who are going to have, report that they do better with the name brand than the generic? Yes, of course, right? You're going to see that. I think one of the only ways is really to try. And some of that can be prohibitive from a cost perspective, like if it's not being covered. And generally, we kind of work through what we're able to get affordably, what we're able to try, and is that working for us? Because if something either isn't working or isn't cost effective, then it's not really a viable option, and we kind of need to move on. Post prostatectomy erectile dysfunction. What can I? Oh, how long do I have to take Viagra and Cialis? Oh, I mean, there's no amount of time that you have to take it. Classically, in that first year after prostate surgery, we see like just a lot of growth, right? Like a lot of return of both sexual function and urinary control. And so there's no set answer where we're like, you must try it this many times. It's more of guiding someone through their recovery when they're ready to try medications. And we try those medications. You may try it a few times. You may try different varieties of medications. And if you're really not getting the results that you're looking for, it is okay, to then escalate. You're probably not going to reach a point of like surgery until about, a year. Because we do want to see if you're getting some of that function back. And it does just take a while, by the time you kind of get through some incontinence issues, try out the medications, maybe try out injections. It could be like a timeline, but it's certainly not set in stone. It's whatever's working for you and your partner, and how important that is too. Sometimes that varies in that recovery process, right? So like you're really get to like drive the ship. Something that's you're going to see some couples where that's like just super important, and then we can support you in that journey. And then there are some people who are dealing with a lot and they just want to put a pin in that for a minute, and that's okay too. um, Do those having a vasectomy have a higher chance for prostate cancer? No, there's been no studies that have proven that. For those who've experienced the loss of length and girth due to Peyronie's, will implants restore those? Good question. No. So, Peyronie's, there's a loss of length that is almost inherent to the disease because of the scar tissue. The goal of intervention with Peyronie's is to get you more straight so that you can penetrate straight and hard, or straight enough and hard. Unfortunately, that loss of length, that loss of girth is something that classically doesn't get replaced, and our goal really is functionality. Next question is, do men develop a tolerance to erection ED medications? Classically, no. It's not that we develop a tolerance. I think it's a kind of a misconception, so it's a good question. It's not really that we're tolerant to it. It's that our erection quality, the disease process itself, has gotten worse over the years, and the medications are no longer able to compensate for that. um, I have a question that's very specific to the rate of success for shockwave for people who've had prostatectomy and radiation. I don't think I have that number off the top of my head. That's a really specific patient group, so I don't think I'd have to look to see if there's any specific rates with that. um, did we cover premature ejaculation? Yep, we did. And you'll get the slides and the the talk emailed out to you, I believe. And feel free to go over those slides and review them. But the main options are going to be a cream. There are some medications. There's some behavioral techniques. And then a question about shockwave. Shockwave therapy are going to be some short sessions, but yeah, there are multiple sessions. If you're interested in the shockwave therapy, we can set you up with a consultation with the office that does them, and you can meet and talk with them about whether or not that's something you're looking forward to do. Again, I think the nice thing there is there's really little to no downside. There's no harm involved. There's no side effects for it. I think that is all of our questions. So unless we have any last questions, I do want to bring your attention to there's a little like screen, I believe, in the corner that has a link to request an appointment. Again, I'm personally in the Dearborn office, but Michigan Institute of Urology has a really broad area of coverage, and there are providers all across those offices who are all wonderful experts in these conditions and can be of assistance in, either getting you started in this journey or guiding you all the way through the journey. So I really encourage any of you to reach out. Thank you all very much. Have a good night.